Welcome everyone to More Good Days, the official podcast of the Haven Headache and Migraine Center. I'm your host, Neda Hindier, founder and chief medical officer of Haven. And our podcast aims to help you stay updated with the latest research, policy changes, and most importantly, practical advice for managing life with headache and migraine disorders. Welcome everyone to More Good Days, the official podcast of the Haven Headache and Migraine Center. I'm your host, Neda Hindier, founder and chief medical officer of Haven. Our podcast aims to help you stay updated with the latest research, policy changes, and most importantly, practical advice for managing life with headaches and migraine disorders. This podcast is designed to provide you with valuable insights and support on your journey to more good days. We're kicking off this 4-part series by diving into the topic of women and migraine. In this episode, we'll discuss menstrual migraine, and in the following 3 episodes, we'll cover migraine during pregnancy, breastfeeding, and during perimenopause and menopause. For this series, Isaac and I are joined by Dr. Susan Hutchinson, who is a personal mentor and an amazing clinician, without whom Haven would not be possible. She's a clinical director focusing on women's health and brings a unique perspective to headache medicine from primary care. Before helping to found Haven, she established the Orange County Headache and Migraine Center and authored a women's guide to managing migraine. A quick note before we dive in, we strive to make all statements in this podcast clinically accurate, but it's not intended to serve as medical advice. Please consult with your provider, or if you're in California, make an appointment with one of our headache specialists at havenheadache.com.
Before we get started on this episode, I want to acknowledge that we are using the term women to refer to folks that experience menstrual cycles and pregnancy, perimenopause, and menopause in this series. However, we do acknowledge that there are many folks who do not identify as women who may experience these cycles of life.
Susan, welcome to More Good Days. So glad to have you on here and talking about a subject that's so close to your heart.
Thank you for having me. Yes, it certainly is close to my heart. Isaac and Nana, as you both know, my background's family medicine. And when you're a female family medicine physician, you see a lot of women. You do a lot of well-woman exams. And I started seeing this pattern of headache around the time of menses that many women thought, oh, it's just part of my PMS. Well, indeed, it wasn't. So that's really what began my journey into understanding more about women, migraine, and our topic for today, which is menstrual migraine.
I think before we get started on that exact topic, maybe we can zoom out and talk about why do women represent 75% of the population with migraine, and how does it change as women age?
Yeah, that's a great point. It's a great way to start, Isaac. When you look at boys and girls, they get migraine at a fairly equal prevalence. And then when girls start having menses and their hormones kick in, let's say, anywhere between the age of 10, 11, 12, 13, then you start seeing the prevalence of migraine shoot up. And very quickly, the ratio becomes 3-to-1, meaning that women are 3 times more likely to get migraine than men. That ratio of 3-to-1 stays fairly constant until menopause, where women are older and they no longer have those hormonal fluctuations.
It's actually kind of the first thing I ask any woman who's coming to me as a patient advocate before I started Haven is like, is there any association between that pattern of their period and migraine? Just how common is it to have menstrual migraine?
It's extremely common. Depending on the study you look at it, it's probably at least 60% of women with migraine have an association with their menses. So definitely more than 50%.
Wow. So if I do my math right, that represents like 45% of the population with migraine in general is this one linkage. That's incredible.
Absolutely. It is such an incredible trigger and such an incredible important topic. So I'm really glad we're just talking about this today.
I totally agree. And it's something I'll always talk to my female patients about is migraine, things that may be associated with their migraine, and most of the time that includes menstruation. So one important thing to think about is our definition. So how would you define menstrual migraine?
Yeah, again, that's a great question. By definition, menstrual migraine would be a migraine that occurs in what we call the perimenstrual window. And what do I mean by that? That means that typically the migraine starts somewhere between 2 days before the onset of menses up to 3 days into the period. And it's important to point out that day 0 is considered the first day of bleeding. So it's about a 6-day window. Also, by definition, a woman does not have to have a migraine in that window 100% of the time. If a woman notices this association with menses at least 2/3 of the time, so on average 2 out of every 3 months, then by definition, she would have menstrual migraine.
Now, is there a difference between women who have strict menstrual migraine and women that have more of a continuum of headache disorders or migraine disorders? And where do you kind of see that line?
Yeah, that's a great point. There is definitely a distinction that I think it's important to make when we're treating women. Do they have pure menstrual migraine, which is the minority of those with menstrual migraine? That would be the woman who comes in and sees, let's say, Netta or I, and she only has migraines during that perimenstrual window. That woman, our strategy can be a little different because we're just targeting treatment for that vulnerable time for cycle. Much, much more common is a woman who has menstrually related migraine. So yes, she gets migraine during that vulnerable time of her menses, but there are so many other triggers for, lack of sleep, stress, change in barometric pressure. So that's the majority of women that, yes, their menstrual migraine may be there, but they often have migraine at other times of the month as well.
And I think we've both seen this. It's menstrual migraine or menstrually related migraine. They can be really challenging to treat at times. And how do you look at treatment for these patients? How do you really like to treat them? And also, what does prevention look like for them?
Yeah, again, great points. Because, as wonderful as some of our acute treatment is, I tell my women with menstrual migraine, wouldn't it be better not to have it in the first place? Would you be interested in us getting aggressive and doing a short-term preventive strategy to really target that really vulnerable time of the month? Because even women that have menstrually related migraine will often say their menstrual migraine is the worst. It's often associated with nausea and vomiting, more refractory to treatment, more disabling. And I think often because of the hormonal changes, it often lasts longer. It's more resistant to treatment. So I think that I really want to minimize the burden for that woman, which is where we often come up with short-term preventive strategies, meaning that we get a little aggressive with prevention, both with over-the-counter things, prescription things, but we really try to get aggressive during that vulnerable time of the month.
Yeah, I totally agree. I do the same, and especially in patients who aren't looking for prevention the entire month. They know that this week is the week that I really want something. I don't want to take something every day. It's a good way to help them in their most vulnerable time. How do you generally treat patients if they're having breakthrough attacks?
Well, first, if they're having a lot of breakthrough, then I need to get more aggressive with my preventive strategy. Because even though we talk about short-term prevention, some women may benefit from being on a preventive all month long, particularly if there's many days outside of that menstrual window. But going back to the question, again, if the woman's having too many breakthrough, boy, do I want to get aggressive with that short-term prevention? And that can look differently for different women, but just to give you a couple specific treatment options, we often use what we call the long-acting triptans. And the two that we use the most would be naratriptan, which some of you may know as Emerge, and frovatriptan, which is Frova. They are better positioned than the shorter-acting triptans like Imitrex and Maxil because they're going to last longer. So studies have indicated you can dose with either of those twice a day for 5 to 7 days to help prevent menstrual migraine. The nice thing is, unlike years ago, they are generic, so they're not that expensive. And so that can be a very good, what I call cost-effective way to try to prevent migraine. In addition, we can do things like magnesium during this vulnerable time, and we can do either over-the-counter or prescription anti-inflammatory medications, things like Motrin, Aleve, Naproxen, which also has the benefit of helping reduce menstrual cramps if that's also something that the woman is suffering with. So, what's nice about all these things we're talking about, they're not that expensive.
Yeah. Yeah. And I use all those same strategies as well. For super severe patients, ones that have been even more refractory, I've even used like IV magnesium around that time to see if it can help break one of those cycles as well.
Yeah, I've done that as well. I've even had a standing infusion order set at a local infusion center. So when the woman gets into trouble with her menstrual migraine, instead of having to go to the emergency room with the bright lights and the noise and sometimes the attitude of the ER staff, they can go into a nice, soothing environment at the infusion center. And they can get things like IV magnesium, perhaps IV Toradol, IV Zofran. And, for many women, just knowing it's there when they need it, boy, did that make a difference in their quality of life.
Yeah, it really does.
Are there any hormonal interventions for preventing or treating menstrual migraine?
Yes, there are. Years ago, there was an investigator, Dr. Somerville, and he took women that had menstrual migraine. He compared what happens if I give them IM estradiol, an estrogen shot, versus progesterone. And he administered what we call late in the luteal phase, just before menses, to see if preventing that drop would help. So when the women were given the intramuscular or IM estradiol, it delayed the onset of their migraine until the estrogen levels started dropping from the shot. When he gave them progesterone, it only delayed the onset of the bleeding, but it did not affect the migraine. So numerous studies since then have shown that probably that drop in estrogen is a much stronger trigger than the drop in progesterone. So if a woman does not have migraine with aura, which is a little more complicated in terms of risk factors, but let's say the majority of women have migraine without aura, then evening out that drop in estrogen or preventing it by things like continuous low-dose oral birth control pills, continuous vaginal ring, that can make a huge difference. And it's particularly good if women need or want contraception, because then you're offering both. And I've seen that strategy be really, really beneficial. But to really work, the woman should not be cycling off and having a period and going on what we call the placebo for 4 to 7 days. It's much better if a woman with menstrual migraine who needs or wants contraception, she has migraine without aura, that she go on a low dose estrogen containing form of contraception and take it continuously and only cycle off if she's having significant breakthrough bleeding.
That's really interesting. Maybe diving into that issue with aura and estrogen, what is the contraindication there, and what do you consider when you're prescribing these interventions?
Yeah, we have to really be careful when women have migraine with aura. And in particular, when you look at American College of OBGYN, the World Health Organization, they really have come out and said that estrogen is contraindicated in women that have migraine with aura. Well, fortunately, the International Headache Society, the American Headache Society, we are not quite as strict because we recognize there's a big difference between a woman who has what I call simple visual aura, maybe 20 minutes of, zigzag lines or spots, and maybe it happens 2 times a year. You're going to treat that woman a lot differently than, let's say, a woman who has uncontrolled high blood pressure, hyperlipidemia, diabetes, a lot of risk factors, and she's getting a lot of aura. So again, I think we can't treat all women the same. So it's really important when I'm talking to a woman to find out, tell me about your aura. I want to make sure it lasts less than an hour. I'm especially reassured if it's very predictable, visual only, and it's maybe 20 minutes. And for many of these women, the aura is only with some of their migraines, not all of them. So again, I guess the bottom line is I really have to look at each woman individually. Now, having said that, I also need to know about other risk factors because the biggest concern is risk of stroke. So I need to know, how's that woman's blood pressure? What about family history of stroke, particularly at an early age? How's her cholesterol? Is she diabetic? Is she overweight? We really have to look at the whole person and look at other risk factors for stroke in order to really be careful in making that decision about whether to use an estrogen-containing form of contraception.
And you basically just answered my next question, which was really how do you screen and what else do you need to look for in these patients? And you mentioned really you have to look at everything else, right? There are other risk factors. Is there a history of stroke? Is there a personal history of obesity, or any other risk factors that we may think about in a young woman in a risk for stroke and for aura? My next question is how do you really monitor these patients? So after giving them estrogen, do you follow them? Do you check to see if their aura changes, if it increases in frequency or decreases?
Yeah, that's really important. So if I have a woman with aura and I made the decision and taken a collaborative approach with her that we feel the benefit outweighs the risk, boy, am I going to watch that woman carefully. I'm going to tell her, if you experience worsening of your aura or your aura is different, it's more complicated, please let me know, because then we will probably have to reevaluate, and then we may have to switch to a progesterone-only form of contraception. And I'm probably going to recheck that woman. Let's say I'm normally going to see a person back in, 3 to 4 months. Maybe that woman, I want her to touch base with me in 6 or 8 weeks. So I think really need to be careful in those women, and they really need to know that you are there for them, because you might have to adjust their treatment if their aura gets worse or more complicated.
Totally agree.
My understanding is there's many types of estrogen. Are there types that you prefer for migraine treatment?
Well, if the woman needs or wants contraception, you're pretty much looking at ethinyl estradiol. That's the most common synthetic estrogen. Now, would I prefer estradiol, which is what we call natural or bioidentical? Sure, I would, but that's not going to prevent pregnancy. So ethinyl estradiol, which is synthetic, it's super physiologic. So it's higher than what the woman's own ovaries produce. And you need that if you're trying to block ovulation and prevent pregnancy. And pretty much ethanol, I think that's what you're going to find in about 99% of the contraceptive options that have estrogen in them.
And I know a lot of women may not have headache specialists if they have migraine or if they have migraine with aura. What advice would you give women who maybe don't have a headache specialist, who to see who could help with this?
That's what I used to try to do, that it was to be kind of that in between, because I find that a lot of gynecologists, boy, they know a lot about hormones. And then on the other hand, the neurologist probably knows a lot about migraine, but not quite understanding the hormonal connection. So I guess what I would recommend is try, if you can, to find a provider that is knowledgeable, not just about hormones, but about migraine, with or without aura. And, you can start with your OBGYN office, because there are gynecologists who are quite knowledgeable. And if they're not, find out, who do you recommend? Who do you work well with? Because ideally, you want physicians working together, or I should say healthcare providers. It could be an excellent nurse practitioner or PA. So for some women, you may have your OBGYN office, your family medicine or internal medicine, and in some cases, neurology. But hopefully they're all collaborating together. Having said all that, I think it would be wise for women who have migraine to understand a little bit more about aura. Because now I've had patients tell me, oh, I get aura. And I said, well, tell me more. Well, I have sensitivity to light before my migraine. Well, that's not aura. Aura has to be specific, reversible neurological signs and symptoms. They need to last for at least 3 to 5 minutes. It's not going to be like 1 second of something. So you want to make sure, because I think aura is both overdiagnosed and underdiagnosed. But if you're listening and you get these weird neurological things, it could be slurred speech, numbness on one side of your body, or tingling. It could be, again, the visuals is the most common, which you may have zigzag lines, things look distorted. Some people have tunnel vision. They can see in the center, but not out in the periphery. So all of those things, maybe draw a picture or write them down, so that you could get that aura. You really want to make sure, do you have aura, and have it properly diagnosed.
Yeah, aura has been also very controversial, and you've probably seen this a lot. I've had a lot of referrals specifically for oral contraceptive pills, and someone who has even a straightforward aura. So we see that many providers really quote this study that was done quite some time ago, looking at birth control pills and migraine with aura. And they mentioned that there was a possibility of a stroke risk. So can you comment on this data, what it found, and whether it really even applies to what we're currently using for contraception?
Yeah, unfortunately, a lot of those studies I think are outdated. They were many years ago. Estrogen containing contraceptive products often contained as much as 50, even 80 micrograms of ethinyl estradiol.
A
That was
lot.
pretty common when I first started practice. And so when you look, you need to be aware too of what's called relative stroke risk versus absolute risk. So here's what we know. We have much lower formulations, meaning lower amounts of ethinyl estradiol. We have some that are as low as 10, 15, 20 micrograms of ethinyl estradiol. And we know from published studies that the increased risk of stroke from being on that in a woman with migraine with aura is so much less than the other formulations that have really high doses. And also sometimes when you look at those charts, there's a big difference again between absolute risk and relative risk. So even if you're going to increase the little bit, sometimes when you look at the big picture, the absolute risk is very low. But again, I go back to the fact that we don't just look at migraine with or without aura and estrogen. Is that woman is she overweight, diabetic? You really have to look again at the big picture.
Just to say this out loud, is there any association of migraine with aura and progesterone-based contraceptive?
Well, there's no contraindication. So in fact, many women that have migraine with aura, that may be a good route to take, particularly if they're overweight. They have other risk factors in addition to migraine with aura. And I especially like progesterone IUDs. Some listeners may know them as Mirena. There's Palena. I think there's one called Skyla. So there's different ones, but I find that the progesterone IUDs don't seem to aggravate migraine, and they're still going to give that woman a form of contraception. The one I don't like, and that'd be interesting in your opinion, I don't like the one called Depo-Provera. That's the injection. Why? You're stuck with it for 3 months. I found that the Depo-Provera often caused weight gain and depression. And sometimes it even seemed to worsen the headaches. So I would much rather encourage a woman to do a progesterone IUD if the woman and I felt estrogen wasn't safe.
I think that's really, really great advice for the young women out there with aura.
Thank you so much for coming on the podcast. I can't wait for the next episode when we talk about pregnancy, but would you stick around for a second for the news and migraine segment?
Be happy to.
So the FDA just approved a new oral combination of meloxicam and rizatriptan called Symbravo to treat adults with acute migraine with or without aura. Is this anything exciting here, or is this just someone smushing 2 generic medications together? Let's talk about it.
You know, I'm a fan of rizatriptan, and I'm a fan of, certain anti-inflammatories as well for migraine. And I'm certainly a fan of combining them together. So I think there are some advantages here, right? Taking one pill instead of having to look for multiple pills, especially when you're in a migraine attack, right? Nobody wants to have to keep looking for things. You just want to take something quickly and have it work. But, what are some disadvantages here? Well, these aren't generics when you combine them together and form drugs. So, there's an expense there, and not a lot of insurances, I'm sure, are going to cover it at first. So, there's certainly pros and cons. If it's something you want to try, but maybe your insurance doesn't cover it, it's not a bad idea to ask your doctor to prescribe both of them. And then you can choose to take one or the other or the combination of both.
I haven't even heard of many providers talks about meloxicam as an NSAID option for migraine. Is it something that either of you have used in your practice?
I don't generally use it.
No, but after looking at the data from this medication, I might start using it more. I think it has a longer half-life, which is an advantage, a greater duration of action. So it is intriguing as to why they picked meloxicam. But I think the proof will be when we start using it in our patients and then getting their feedback.
Yeah, it was an interesting one that I was surprised by as a patient.
I'm always excited to try new things because you truly never know until you start using that and prescribing it, and then you can see how your patients feel about it.
I mean, it's certainly interesting to see any study on combination therapies, which are very rarely done.
Yeah. So
it reminds me of when Trexamet first came out. And Trexamet, of course, is the combination of Imitrex, which is Imitrex with naproxen. And I was very skeptical when it first came out, thinking, well, we could just do the two generics, as you said, Isaac, smush them together. We used to have a saying, 1 + 1 is 3. There was something synergistic about being in the same tablet. Some uniqueness about the PK data. And I think that's going to be the same with this meloxicam rizatriptan. We're going to see a different pharmacokinetic profile that's going to be favorable to the patient. So I'm excited. I'm excited to start prescribing it.
I used to work in a pharmacy, and pharmacist accidentally broke in half one of those tablets while packaging it up. And it is literally the Imitrex naproxen combination. It literally looks like a generic Imitrex wrapped in an naproxen.
Yeah, I mean, I will tell you that it worked well, not just for my patients, but for me, myself. I don't get migraines anymore, but that was my go-to. That was my favorite.
Yeah. Well, Isaac, are there any policy updates?
This one actually comes from our friends at Headache on the Hill. It's been something that they have advocated for a few times over the years, which is expansion of the use of 504 plans. If you're not familiar with 504 plans, they are on the spectrum of special education plans for people who are K-12 to help them get accommodations. 504 plans are often more accessible than its bigger brother called IEPs, and can be a much faster way for getting parents to seek accommodations for their children. And the Department of Education wrote a clarification that allows for migraine and enforcement for migraine as a 504 protected accommodation set. So students with migraine, of course, with a letter from their provider, can get substantial extra time for assignments, tests, things like quieter or dimly lit environments to take tests or do work, resting areas, and acknowledges the substantial limit of operation of neurological and brain systems and major body functions that happen during migraine. So this is just really exciting news. Although we don't yet treat pediatrics, it's still a really exciting folks for hopefully the parents. As we know, migraine is so genetically driven that they can help their children faster.
This is so important because, it's oftentimes the stress of knowing you're going to be in an environment that's not conducive to migraine. That's certainly going to bring one on. So knowing that there's something you can do to help limit that exposure and be in a safe environment, I think that in and of itself can be a helpful preventative for another attack. So it's really exciting changes.
I will say, just as someone who comes from this world and actually personally had an IEP growing up, not just for migraine, but for dyslexia, 504 plans will be easier to get to begin with, but they're harder generally to enforce than IEPs. So the tip to a parent who has a child in this situation is start with the 504 plan and work up to that IEP to potentially have a more faster track for your child.
Advocate as much as you can for your family.
Absolutely. And we'll include a link to that guidance in the episode notes. Thank you so much again, Susan, for joining us.
Thank you, Susan.
Thank you. It was a pleasure to be here with both of you today.